Good afternoon, everyone. Thanks for the diehards who are sticking in here. So it's my honor to really talk about a topic that's near and dear to my heart, which is pain during cesarean delivery. Some of you may know some of the things I'm about to talk about. Some of you may know nothing about it, so I kind of incorporated a little bit of background in here. But we'll just get started. Okay, first off, I have no financial disclosures to make, but I have a couple fun disclosures. Number one, 25 years ago, I did work as a bartender in this facility, so it's good to come back as in a very different role, because I did bartender here for years. I know, you're welcome. And secondly, I am post-call, which means if I make mistakes, please just clarify in the questions later. And also, I did add some audio clips, which just increases the level of difficulty, so have some patience for me and my cognitive load of post-callness. All right, so we're going to talk about the learning objectives quickly. We're going to explore the topic of pain during cesarean delivery. We're going to talk about some of the contributory factors, and I think this is where the bulk of what I'm going to talk about is today, and what I've really learned in the last couple years. And then we're going to explore some solutions, but I'm not going to spoon feed you on those. So many of you have already heard about this. Many of you may have listened to this. Maybe some avoided it. Who knows in the room? But The Retrievals is really a podcast via the New York Times and Serial Productions that focuses on women's pain and undertreated pain. And season 2 aired in July of this year, and it focused on pain during cesarean delivery. I put two figures up here who are prominently figured in the series, and this is Susanna Stafford and Clara, and I'll just use Clara because of her last name. Nobody ever uses it. I know her personally. But they really were two very brave souls who shared their stories and really brought to the forefront what's happening in ORs across the country and some work that we have to do. So we'll start with Clara. The episode 1 starts with Clara's story of her delivery. Now, full disclosure, she is a labor and delivery nurse who works at the University of Illinois, which is where I am from. So I know Clara very personally. She comes in for the induction of her labor. She has a twin gestation. The obstetric history, not really relevant in this case, except for the fact that she gets an epidural, which I place. You'll find that out in episode 1 as well. And then I leave and she has to go for C-section. So as she goes in for C-section, some things happen that really highlight, kind of some of the cognitive misses we can have as providers. So she's dosed up with her epidural. She gets 2% lidocaine with epinephrine and bicarb. She is prepped on the OR table. They do the skin prick test, which we institutionally do with a toothpick, basically, or kind of a tongue depressor that's broken off. She passes that with flying colors. They do an Alice test, which if for anyone in the room or any patient advocates in the room, what they do is the surgeons will actually take a clamp and go along the incision line, make sure the patient's numb. She passes that as well. Unfortunately, she starts to have some, what she thinks is anxiety. She really doesn't feel well. And so she decides that maybe she'll get some anti-anxiety medicine because she's feeling uncomfortable. But it soon becomes really apparent that she's starting to feel intense pain. I'm going to see if I can get this first audio clip to play.
Clara's anesthesia is not working. She is now in the middle of major abdominal surgery, and she can feel that surgery. Clara knew this could happen. She had seen this happen. Intraoperative pain during cesarean, healthcare providers know about it. Patients don't. When Clara herself first started working on L&D, and patients in labor would tell her, "For my last baby, I had a C-section and I felt everything," Clara would think to herself, "That can't be true. There's no way. Who would do that?" And then she saw it happen, and now it is happening to her. Visceral, that key word. What Clara is feeling is visceral pain, meaning pain that originates inside her abdomen. When the doctors did the skin test, Clara didn't feel it, right? She was numb. But sometimes a cesarean patient is numb when you test her skin, and when you open her up, you find she's not. There are a lot of reasons for this, but in the moment, the reason for the pain doesn't totally matter. What matters is that you treat it.
So in this operating room, she's experiencing intense pain. She continues to stay awake for the procedure. She's given 300 of fentanyl, 60 of propofol, 0.8 of Dilaudid, 6 of midazolam, and 32 of dexmedetomidine, which, for relevance, if you're not in the anesthesia world, is a huge amount of IV sedation. Despite that, she's moaning, she's screaming, she's saying, "Help me," and her partner is sitting next to her. So following the surgery, she clearly is traumatized. She's experiencing signs of PTSD, she's having flashbacks, and she's having difficulty returning to work. So it's pretty much undeniable at this point, with the amount of publications that we have, that ultimately we know that pain during cesarean delivery is real. It's a phenomenon. It hasn't been well defined, but patient stories are telling us that for some patients, it's very traumatic, and it's not the experience we would ask anyone to have. Now, I told you that I've been thinking about this a lot, and so I kind of summarized what my thoughts have been in the last 2 years. I've been lucky enough to kind of be in this space for a little bit. Clara's surgery was in 2022, and at first, when I heard about this, I was furious at the provider. I was so mad I couldn't even see straight. I was pacing, I was angry, I was sweating. And I had to talk to this individual, and all I wanted to do was slap him. Now, it's not a very mature response, I get that. And as a leader, it really wasn't the right response. But it's how I felt. And when I talked to this individual, I realized that there was a perspective, and there was dogma, and there was kind of hidden ideas that I really didn't understand that are influencing the way providers practice. So I want to take a moment and talk a little bit about all the lessons I've learned in the last couple of years from talking to providers, talking to patients who've contacted me, and also even just listening to the podcast. Although I was in it, I really didn't hear the entire product until the end, and I learned things. I thought about new things as it came out. So first off, Neuraxial is not always enough. We have a patient here who passed her skin test, which is our best metric of can we proceed, yet intraoperatively had tremendous pain. There are 2 types of pain that we have, somatic and visceral. You heard Susan talk about it. Not all of our neuraxia will block the visceral, and that is where the problem starts, because we are testing the skin. And so we have providers who stay the course and say, "She's numb, I've tested her, her block is working," even in the face of a patient who's moaning and screaming and saying it hurts. We don't see it as pain because it can't be, because it's the skin, and that's just wrong. We have to change that culture. Secondly, this idea of failed, and in the literature, failed neuraxial. This is an expected outcome, that some blocks will not be dense enough for abdominal surgery, and we have to accept that as a risk. We have to know that that's not failure, it's only failure if you don't treat it. So we have to change it to inadequate analgesia, inadequate or unoptimized analgesia, and we can do things differently. And this, in our system, led us to look really deep in the literature and figure out how can we densen our blocks. And we made it mandated that in our unit now we use fentanyl and clonidine along with local anesthetic in all of our blocks in order to really hit every receptor we can before we say it's inadequate and we have to convert. The ASA has done some great work here, right? They've published some really great statements, and especially the use of adjuncts during cesarean delivery. But really, this is a punch list of things you can use. It was meant to normalize the idea that we can give pregnant women during a C-section IV agents to help their pain, and that it's okay to have general anesthesia. But it is not an algorithm. There is no information for providers to use to say what to do where. And that's the problem, because there's no teaching in this. There's no textbook I can give you in this. I've searched, I've looked for algorithms, and no one has this. We all learn by role modeling, we all learn by talking to individuals, and many of us have it wrong. So it's not a surprise that this is happening. Next, we have bias. So there's a couple things here. When we talked to the provider, and I talked to the provider about what was going on, again, he had some really enlightening things to say, and I just want to play that little clip of me discussing my conversation with him. Can we play it? It should be in the corner. let's see if I can get it go. Okay, we'll skip that one. There you go, thank you. He kept saying to me, well, she has anxiety. And so we kept giving her like anti-anxiety medicines. And I said, but she was telling you she was in pain. And he's like, oh, well, she had anxiety. She was just very anxious.
The anesthesiologist had repeatedly mislabeled Clara's pain as something else.
It was also, well, the patient was having a lot of pressure. And that's when that word really became a dirty word to me. I was like, yeah, but no. So we saw that this provider said she had anxiety. That's why he gave her 6 of midazolam to treat her anxiety. She also got nitrous for anti-anxiety, which she had requested, and that was okay. But what we find is that there are providers who attribute patients' pain, especially women, to anxiety, and that's not always true. So there was a really smart study by Keltz et al., and what they did was they took patients, it was a prospective observational study, and they took patients, and then they took anesthesiologists and OB providers, and they debriefed after C-sections, and they asked patients how many of them had pain intraoperatively. We found about 12% of the patients had pain. Doesn't talk about severity or any of those things or where they had pain. But when we surveyed the OBs, it was about 4-5% of OBs thought that patients had, or they thought 5% of the patients had pain. So they were missing a significant number of patients, right? Well, what about on our side of the drape? What about on the anesthesiologist side of the drape? Well, we thought it was about 16%. So we did much better, clearly. However, our number of false positive and false negatives was unacceptably high, which means we attributed pain to anxiety more, and we missed patients who had pain. So we're terrible at this, and we just have to accept that without asking a patient, we have no idea what's going on. In my clinical practice, with some of the systems we design, I've really found that this to be 100% true. So we really need to take anxiety out of the picture and talk about pain. We need to teach our trainees, we need to teach our providers that there are 2 separate questions. Are you having pain? Are you anxious? They are 2 separate things, and we do not treat pain with anxiety medicines. If we look at overall numbers of pain during cesarean delivery, they vary widely. Now, why do they vary? Well, they vary because if you survey the literature for studies that have used surrogate markers, including conversion to GA and the use of IV adjuncts, you'll see very low numbers. Why? Probably we're missing that patients have pain. But if you ask patients, you're actually going to see the higher numbers. So let's take those as the real numbers. Let's say that that's real and not what we think, because we know we're terrible at this. So we're talking about 33% of patients who have an epidural may experience intraoperative pain. That's 1 in 3. That's a huge number. That is the highest risk factor you have going into an operating room from anesthesia, and we don't talk about it with patients. That's a crime. So what did we do to change this in our own unit? Well, we started working on communication a little bit, right? And so what we found is that our communication with patients is really poor, right? We're not asking questions the right way. We're not using language that empowers them. There's a hierarchy that is described, right? And patients want to please us. They want to get it right. They're thinking about their baby. They don't want to delay care. And so they often may not tell you exactly what's going on if you don't ask the questions the right way. We can play the clip, please.
The anesthesiologist repeated the same test and the same question multiple times.
It was very clear to me that I was not answering the question correctly. And I'm the sort of person who likes to answer questions correctly.
Susanna was lying on a table, looking up at the anesthesiologist. She was aware the room was full of people who were waiting to begin. She felt embarrassed by the amount of time she seemed to be wasting. The anesthesiologist asked again if Susanna was ready. This time she said yes.
And I knew I had given the wrong answer when I felt the first incision. And that felt like I was a beanbag being opened up.
So you have a patient who's very, very a self-advocate. She describes herself as such. She is informed, she speaks English, she's in the UK, she's with a provider of her own ethnicity, and she couldn't tell the providers, no, I feel pain. She felt embarrassed to do so because they kept asking her, well, you're ready now, right? You're ready now. And she describes this in detail in other settings, and she has videos on this as well. But ultimately, we're missing the mark with getting the information from patients. Another lesson I've learned is that it's not always dismissal of pain. It's not always communication, but fear drives a lot of our choices. So I'm going to play a clip that's from a SOAP 2023 lecture that I gave where I kind of crowdsourced and I asked the audience kind of what's causing this? And there was a very senior member of our audience who came up, very seasoned, and his comments were very enlightening.
So that, for me, it's not just about, oh, the patient's comfortable or she's just exaggerating. It's sometimes that fear that if I do get into a general anesthesia, no one knows how to help me.
Sorry, that's the second clip. There's another clip. Can you play that one?
When we think about why this happens, I think there is this specter in the back of our heads that says, oh crap, the spinal's not working. If I have to induce general anesthesia, there's a chance, because we all have PTSD, that the pregnant airway is horrific, that I'm gonna lose the airway and the mom will die. And I think that is what is, I mean, I'm gonna say it, that is a fear of mine, that I will lose the airway, and then they'll be like, well, yeah, she was uncomfortable, but maybe you could have muscled through and at least she'd be alive.
So you hear that fear of losing the airway, fear of over-sedating and losing the airway, fear of impacting breastfeeding, fear of being judged, right, as well. That's kind of come up with, we're using metrics for GA that maybe aren't really allowing our providers to feel empowered to make that choice. They feel that somehow that's the wrong choice. And then the first clip that we heard, it was a provider in community practice, and that's become more important to me lately because I work in a community practice for part of my call, where she didn't feel like she had the right resources. She didn't feel like if she got into trouble with the airway, there was anyone to help her, or even just help her start, right? Depending on where you practice, that may play a really important role in why you're fearful. It's not that you don't know how to do an airway, but you have no one to hand you stuff, no one to assist you and make sure that it's done safely in the same way that you might in the main OR. Not all of our nurses on L&D are trained. Next, I've learned that fear, there's a lot of focus on the fetus, that this really comes into play, right? There is this coercive language we use. Well, you know, we're gonna make sure your baby's okay. We have to deliver you now because your baby, your baby has to be delivered. You want medicine after the baby's delivered. These may be impeding people from asking the right questions intraoperatively or treating appropriately. And this really comes into, the pervasiveness really comes into a quote from Susanna, one of the patients that I would like to play next.
So when the community midwife came to visit me, I tried to say something about, you know, the operation had been a bit traumatic. And she went, oh, never mind, dear, the baby's all right, that's all that matters.
So you can see, your baby's okay, that's all that matters. And for a lot of women, that is the outcome that they need, and that is the one that's most important to them, and it does impact their experience. But we have to strip away this idea that every decision a woman makes when they're in labor should be in service of what's in their uterus. They have the right to be comfortable. They have the right to be respected. They have the right to get good care and have a good outcome with their child. And I think that's so important because there's no other part of anesthesia that anyone has to make that choice. No one has to make a choice between their knee and their child. And it's a part of the language that we use that we have to strip away. It's coercive in nature, and it's developed over years, and it's societal, but we have to recognize it. And then culture, don't cross the drapes, right? One of the things I said in the SOAP lecture in 2023 was, one of my proudest things is that I have a unit that trusts their anesthesiologist. They love us, they consult us, they trust us to provide good care. But it was one of the biggest downfalls in the case of Clara, because everyone in the room knew something was wrong and no one challenged the anesthesiologist. It was anesthesia's job. Don't cross the drapes. They're responsible for that. And that's a problem. We need to pull that curtain down. We need to make it a team-based play, and we need to have all the same shared mental model. So what kind of language do we do to normalize pain? You hear these things like, is it just pressure? right? Just pressure makes it sound like that's okay. It's normal, right? Again, one of my favorites. It's normal to feel pressure. Nothing about pain in there, it's pressure. And then finally, it's almost over. So what we're telling our patients is bite the bullet. What other surgery do we do that in? Never. We never do that. And this is something that happens again and again and again in the OB realm, right? Why? We don't understand it. It doesn't make sense. Is it because birth's supposed to be painful? Is it because we're uncomfortable with alternatives of treating the pain? Maybe. And then finally, if you don't believe me that culture plays a huge role, I want to play this next clip for you. And this is one of the nurses who was a friend of Clara's, who was in the room at the time that she was delivering. Thank you.
And it wasn't until she just kept begging, like, please, please, please. And one of the attendings, she looked at me and told me to tell her that it was okay. She told me to tell her partner, please tell him it's okay. So at that moment, I was no longer a friend or like an advocate. I was more like a staff member being told by the doctor, like, it's fine. So I remember telling Clay, like, Clay, you know, this is normal. This sometimes happens. And Clay, I remember his body language was very like, yeah, okay, like, I hear you, but don't talk to me. And I remember being like, oh my gosh, because he was so stressed out.
So what else do we see, right? What else do we see? Well, we see the consequences, or now we're starting to see the consequences. This is something I've really learned. I did not know what was happening to women after they left my care. I didn't know that the long-term consequences were preventing them from future pregnancies. And so Tracy already spoke about trauma-informed care, but she was also at that SOAP meeting in 2023. And I'd like to play her clip, just the summary, because I think she's going to say it better than I possibly could of what it looks like for these patients. Let's see if we can play the clip. Thank you.
I can't stand here and overemphasize the impact that this has on individuals, their relationship with their babies in the terms of decreased bonding, decreased breastfeeding success. You mentioned the husband in this room. The impact on him, on the partners, on their relationships. Believe me, I've worked with so many women. I hear 11 traumatic stories a week. These are individuals that go on to get divorced. They can't even care for themselves. It rocks relationships. The mental health complications, I have women who are still having suicidal ideations years later. Their birthdays of their children become nightmares. The impact is so severe. I can't stand here and
So we've talked a lot today about implementation science, and one of the branches on that was, what's the data, is it supportive, right? Grace came up and talked about this beautiful project she's doing, which I'm so thrilled that she's doing. But those things take years. Those things take years to do, and sometimes you don't have the initial data to say what you're doing is different. I couldn't wait. I had an individual in my institution who got harmed. I had an individual who I had to bring back to the operating room for her first C-section and watch her panic as a patient said she was feeling something. So I couldn't wait. So we made some changes at our institution. I just like to quickly run through them, and I know I'm gonna go a little bit over, but I'm hoping that you'll be gracious on this one. Sometimes you need to do, and then you need to figure out what works. And when you have this many patients who are potentially at harm, I think that that's the right move. You can't always wait for the data, or some of the studies will never be done. I'll look forward to implementing them when they're there. So we have incorporated a pre-op discussion about the risks of anesthesia, right? And that includes not only neurological implications, not only post-oral puncture headache, but the most common thing that can happen to them in the operating room, which is pain during cesarean delivery. This is not to scare patients, but it's to inform them, because it's an opportunity for us to now have the discussion of, you are in charge, your pain is important to us, and we're going to be asking you about it. And here are the things we can do. Also, if you're anxious, we have things we can do. Here's the impact on the baby, here's when we can do it, and here's what it looks like. And it allows patients to go to the operating room more informed. Secondly, we have scripts that we give to all our providers, our OB providers to have with our patients in pre-op and during their prenatal care, our OB nurses, so they're not just saying, oh no, you'll be fine, the anesthesia is going to take care of you. And then for our anesthesia residents who find this conversation incredibly awkward, we give them a script, we give them words to use and language that we think really helps start the conversation. We have more precise sensory tests that we use. And what I say about that is, yes, we still test the skin the same way. Yes, we still do an Alice test. But if any patient has intraoperative pain, we actually do a skin test around the incision. We pull the retractor up, and then we manipulate the uterus, and we see where the problem is so that we can target our therapies, and it's not just she has pain. It is she has pain that is somatic, she has pain that is visceral. Where are we in the surgery? Can we adjust things? Can we move things? But our OBs know to do this full exam for us, so then we can talk about how much longer in the surgery we have. Is it right to continue to do IV medicine? Should we go to sleep? This allows us to have more information. We have some communication around pain expectations and intra-op communications. So there's a couple parts of the surgery that are painful. When you deliver the baby, someone's physically leaning on you. We can't block that fully. Most patients feel that. So we tell them that, and we give them the expectation that it will be a very short period of time. And our OBs will now warn us before that's about to happen because they know the patient needs to know. They don't just start pushing on the belly without telling them. Number two, when they do the gutters, when they kind of do the upper areas and they're looking for hemostasis, they will warn the patient, you're going to feel something for a minute, but then it'll be over. And okay, is it over? Fine. Because a lot of times the patients do feel that. And if it happens to them suddenly and unexpectedly, they lose trust. They wonder if they're going to feel it again. But if we let them know, if we give them the timelines, if we act as a team, it goes much better. We've also talked with our OBs about surgical interventions. Number one, don't exteriorize the uterus. And so now my OBs stand there and they kind of look at me very furtively and they're like, we're gonna have to take it out. And I'm like, okay, let's make sure we're fine. Or they'll be like, nope, we're good, we're gonna keep it in. So they're training their next generation of residents to try to keep the uterus internalized. And secondly, we have the right to call their senior members into action. We know that the longer a surgery is, especially with spinal anesthesia, the more pain a patient can have. So we reserve the right to say, hop your senior in there. This is no longer a junior case. We need to speed this up. Right? And I'll tell you, just having worked in community practice where the sections are all 45 minutes, we have much less pain than the 2.5-hour sections that I'm in my tertiary center. So we have to think about that as something that we have to push forward. We all have to say that that's how patients will thrive. Communication, we now have a very patient-centered communication, all right? And so in the operating room, we will again reiterate that pain is important, and we will let them know that every 15 minutes we're going to be monitoring pain scores because their pain is important to us, and at any point they want us to stop, they have that right. I tell patients you are not supposed to suffer during this surgery. There is no advantage of you suffering, but only you know if you're suffering, so you have to tell me. I try to enable that. We have translators at the bedside the entire, in a phone, the entire surgery if we have someone who doesn't speak English to enable this. But as I said, we monitor pain scores every 15 minutes. If the score is higher than 3, our providers have to stop the surgery and do some form of intervention and have a conversation with the patient. And you'll see on the bottom there it says patient's reflections or patient's comments. We actually record what the patient is saying because some of them will say, it's a 4, but I want you to continue. I don't want anything. We put that in the chart. But 15 minutes later, we're back with that patient saying, do you want something now? Because we want to make sure that they don't feel like once they've made a choice, they're locked into it. And I think that that's really important. This has altered our outcomes tremendously in our operating room, and it gets providers to treat this seriously. Have our rates of general gone up? Absolutely. Education and coaching, we need to make sure that all of our providers know the right drugs to use and that our OBs are willing to wait the allotted amount of time. So we give them education on, if I need to put more medicine in the epidural, we're all gonna stare at each other for 5 to 7 minutes. We're all just gonna stand here. And they know now to be patient. If I need fentanyl to work through the IV, I say you're gonna need to give me 3 minutes until it's peak effect. We do not let them proceed. They know the timelines now, and they know that it's not magic, that what we have to do takes titration, it takes time. And so this is really important. And then we also use the data from our EMR to go back over cases where patients did have pain and say, did we use the right therapy? Did this work at this time? Should we have converted general? And then we have accountability. The entire team has the ability to call each other out, right? So May talked about this, speak up. It's very hard in these hierarchical systems, but now anyone in the room can say stop. And everyone does. Often there's a thank you, she's in pain, okay, we'll stop. And I think it's really changed the culture to allow us to catch up and to be really more mindful for the patient. We have debriefings, and so we ask, did the patient have pain? Was it treated? Should we have converted earlier? Was anyone uncomfortable with what happened, right? These are conversations that we have after a patient may have pain. Sometimes they have an unavoidable pain. Sometimes we're suffering through because the patient's like, I really don't want anything. But is that patient going to have PTSD? Are they going to be dissatisfied? No, maybe not if they had the autonomy to make that choice, right? So, and then finally, what I've really learned is the power of the media. We could have been in these conference rooms with 100, 200 people. I could have been on the circuit for, repeatedly for a year and a half. But there are millions of people listening to this podcast, patients, providers, spouses, right? And the feedback that we're getting from all the different various characters, because they've all reached out from different people, is that people are really happy that this is coming to the forefront. They're really excited that things are changing. They're really excited that they feel like they can talk about this. Some of the survivors of this are thankful because they thought they were alone in this, and to know that they weren't, to know that their experience was not singular, there's nothing wrong with them, is incredibly comforting, right? And we've had lots of groups reach out to do journal clubs, right? I know there was a group from South Africa last week when I was at the World Conference of Obstetric Anesthesia who basically said, we did a journal club on this as an internal group, and we looked at our process and how we think about this. And so I think it's a really healthy thing. So we need to learn how to partner with media to get the message out further, because we tend to talk to ourselves, and that is a problem. We need all hands on deck on this one. And then finally, I'm just going to make one little plug here. We talked this morning about patient safety bundles. I believe this falls in the category of preventable harm. I believe that this is a real health risk. So I pitched it in 23, I pitched it in 24, and I'm pitching it in 25. Let's build a safety bundle around this. This is preventable harm. Thank you for your time.